We are live.
Hi, hello, and a very good evening. I welcome you all to today's iFocus online session, lecture number 520, Eye in Systemic Diseases, module number 11. Today, we have with us Dr. Jyotirmay Biswas from Nethralaya, Chennai, to talk on eye in systemic parasitic infections. And he's the stalwart. Nobody else can talk regarding this better than him. A brief introduction. Sir has done his fellowships in vitreoretinal surgery from Nethralaya, Chennai, ophthalmic pathology from Doheny Eye Institute, University of Southern California, United States. Current position, Director of Uveitis and Ophthalmic Pathology Departments at Nethralaya, Chennai. Also, visiting professor at the Advanced Eye Care Center, PGIMER, Chandigarh, and the University of Hong Kong. 60 awards, including Hari Om Ashram Alembic Research Award from the ICMR, awarded by the President of India, and recently the AIOS Lifetime Achievement Award 2025. He has mentored over 61 fellows, and he's a member of the International Uveitis Study Group, American Uveitis Society, and International Ocular Inflammation Society, and a fellow of the Indian College of Pathologists and American College of Surgeons. He's the founding member and the past president of Uveitis Society of India, founding president of the Society of Inflammation Research. He has published over 500 articles in PubMed Index journals, 70 book chapters, and 5 books on uveitis and 1 on ophthalmic pathology. He has presented over 300 papers in various national and international conferences, and he is listed in the top 2% of Indian researchers in ophthalmology by the Stanford's top-cited researchers ranking from 2023. We are very honored to have you here on our iFocus online session today. Thank you so much for joining us, sir. Over to you.
Am I audible?
Yes, sir.
Thank you for the kind introduction. It's actually, it matters what is that all these designations and definitions and numerations doesn't matter. I feel that how good a human being you are, that's the most important. Whether you are helpful to patients, you are helpful to the students, and that's the main, at the end of the day, at the end of my career, I feel that that is more important. I feel really humbled and grateful to get the opportunity to talk on a subject which I have worked on it, parasites of the eye, eye in systemic diseases of the systemic parasitic diseases. I have been enamored by the several parasites inside the eye and I took a lot of interest in doing that job. Today, I will be showing you some of the parasites of the eyes. Not all I can show, but this is a great collection. If I'm too lengthy or too prolonged, please pardon me because it's close to my heart. What are the parasites? Parasite is a living organism that receives some of the basic nutritional requirement through intimate contact with another living organism. That's parasite. And there are several parasites in the body, eye, and as well as in the body. Those which are in the body and affect the eye, I am talking about them. And mainly I'll be talking on the toxoplasma, which is the most common parasite in the eye. But rest of the parasites are not that common, like Cysticercus, Toxocara, Hydatid cyst, Filaria, Gnathostoma, DUSL. They're exotic. Coming to the toxoplasma, I'll be spending a little bit more time on toxoplasma. It's an obligate intracellular parasite. It has to be remain inside the cell. Nicoli and Monkenes first described this organism in 1908. That means it's quite an old organism. It's nothing new. Named based on the Greek word toxan, meaning arc. It's a boat-shaped organism. And the gondai, the word comes from a rat. From the animal, it was from where it was first isolated. This is a brief history about it. I'm not going into the details of it. The parasite, the definitive host is the cat. Definitive host is the cat. I'm not going into the details of that one, but you can get the parasitic infection by contaminated water in the cat's stool, or the taking the meat from the uncooked meat where the parasites are there, the intermediate host, and there you can get. The Toxoplasma gondii had three cell infective forms: tachyzoid, bradyzoid, and sporozoid. Tachyzoid is the small one, and bradyzoid is the cyst form. Humans becomes infected after eating uncooked meat or unwashed vegetables, particularly contaminated water. I'll be showing a article which has been published from Salem, from Coimbatore. This was a very interesting article. Outbreak of acquired ocular toxoplasmosis involving 248 patients. What a big number. What happened in Coimbatore, one of the municipality water tank that got contaminated with the cat was there, and cat stool contaminated, and it infected the whole populations over there, the municipality population, and they saw as many as 248 patients. So water can be a very good source, contaminated water or uncooked meat or unwashed vegetables can be there. So you can ask, when you ask the patient that, have you got a cat in the house? They would say that no cat in the house. But that doesn't matter. If the cat stool contaminates by vegetable salads which you are taking, or you take some uncooked meat. In Nepal, they found that uncooked meat one of the source of toxoplasma. So these are most common infective cause of posterior uveitis in immunocompetent individuals in the world. But in India, when I did that study of the pattern of uveitis, toxoplasmosis is 1995 was the most common posterior uveitis. Since then, hygiene of India has improved, and now in 2013, 22 years after, when I did the analysis of the posterior analysis of the pattern of uveitis, I found not toxoplasma anymore, that tuberculosis is the most common cause of posterior uveitis. Most cases subclinical or benign, prevalence higher in the tropical countries. Two types of toxoplasmosis we see is the congenital and acquired. And this is a publication we made in Ocular Immunology and Inflammation, Ocular Toxoplasmosis in Tropical Country, analysis and outcome of 190 patients from a multi-center collaborative ocular study. So this was I was a part of this study, and we saw the various pattern of toxoplasmosis, and I'll be showing you the various pattern, many phases of toxoplasmosis. I diligently collected many toxoplasmosis cases, and this one is the congenital toxoplasmosis. I don't know whether you see the arrow, and this is the acquired toxoplasmosis in just above the optic disc, and this is a toxoplasmal lesion by the side of a previous toxoplasmal lesion, congenital toxoplasmal lesion. This is a recurrence of toxoplasmosis. This is a kind of a linear scar of toxoplasmosis. This is a toxoplasmosis with retinal vasculitis, sclerosis, arteritis, and here is a exudative retinal detachment, the toxoplasmic retinitis. So talking about congenital toxoplasmosis, we are not seeing that many because nowadays that vaccine is given, immunization is done. Transplacental transmission is one of the reasons for getting the toxoplasma. Lowest incidence is first trimester and highest incidence in third trimester. Asymptomatic in 90% patient, and we get a punched out chorioretinitis, retinochoroiditis or chorioretinitis, punched out. once you see one toxoplasma, congenital toxoplasma lesion, you will not miss it. And they are always almost in the posterior pole. They can have other features like systemic hydrocephalus they can have. So nowadays we don't see the congenital toxoplasmosis that very common. And this is acquired toxoplasmosis. This is unilateral in 70 to 83% of the cases, presents with dimness of vision with sudden onset of floaters. So the main complaint of the floaters, and when you start looking at the lesions, you will see the headlight in the fog appearance. Like, the car headlight in the fog is appearance, and you see a toxoplasma lesion sitting on the back of the fog. And this is the acquired toxoplasmosis, recurrence of congenital scar over here, and by the side of you can see a recurrence of toxoplasmosis. And this is retinal vasculitis, and you can see the toxoplasma lesion over here. And beyond the lesions, you can see the retinal vasculitis, sclerosis arterialis. These arterioles are involved. You can have peripheral toxoplasmosis, and this is a granulomatous anterior uveitis can be there, but this is often associated with the posterior lesion. I saw this patient and I made a mistake. This patient has got mutton fat keratic precipitated all throughout the posterior surface of the cornea. I thought that this is TB. I did an AC tap and we had a facility to do that. AC tap PCR came for positive for microcystic tuberculosis. I have started treating with antitubercular treatment, as well as I put on the patients a topical steroid and a systemic steroid. But lo and behold, what I found, once the vitreous is cleared, it's not the TB lesion, it was a toxoplasma lesion. And PCR was false positive. So always believe in your clinical acumen. Don't fall in love with the diagnosis. Always prepare to change the diagnosis. Toxoplasma can produce anterior uveitis, and not necessarily that could be due to tuberculosis. And this uncommon presentation is bilateral involvement. There's multifocal choroiditis lesions, particularly in the HIV positive patient, low grade or absence of vitreous inflammation, size of an active lesions more than 2 days diameter without a retinochoroidal scar, optic disc involvement. Optic disc involvement can be there. Choroiditis without retinitis, SAS retinal detachment, hemorrhagic vasculitis, retinal neovascularization, which are very, very rare. But most common is the focal retinochoroiditis with headlight in the fog. There should be a localized vitreous haze. If you don't see vitreous haze, you need to revise the diagnosis of toxoplasma. And in case of HIV positive patients, it's a different ballgame. They can present as a necrotizing retinitis and mimic as a viral retinitis. This is a patient, 51-year-old lady, PCR from the vitreous biopsy was toxoplasma positive. And this patient was treated with intravitreal clindamycin, and how you can see that nicely respond, and the patient preserved the vision. So HIV positive patient, any necrotizing retinitis, keep toxoplasma in the differential diagnosis. So this is an article published in American Journal of Ophthalmology in 1988, and they were seen ocular toxoplasmosis in patients with acquired immunodeficiency syndrome. A lot of patients, autopsy eyes were available, and my teacher, Dr. Narsingh Rao, and others, Gary Holland and etc., had published that lot of patients unheeded, a lot of patients hidden toxoplasma lesion. Eyeball, when is removed in the autopsy eyes, they could see the toxoplasma gondii organisms. And we had a ocular toxoplasmosis in HIV, and it was a 3.5% of the cases of AIDS-related retinal infection, less common than toxoplasmic encephalitis. Encephalitis doesn't occur; they occur in AIDS patients quite common, but toxoplasma infection in the retina in HIV positive patients is relatively rare and is fortunate. Serious lesions in 20 to 50% of the patients with ocular presentation. We published a study in 1993 to 2006. 2.3% of the total cases were toxoplasma, ocular lesions in HIV. 2.3%, and 40% was bilateral. So unfortunate that I didn't compile these cases and couldn't make it a publication. It would have been a very good publication, but it left like that due to the paucity of the time as I was talking to you. But this was one of the cases which I've seen, and you can see that lesions are much larger than what you see in immunocompetent patients, and they can be bilateral also. Individual appearance is simple demarcated borders and minimal retinal hemorrhages are seen. How to investigate? Forget about the list of investigations will be seen in the textbook. Just one investigation is important. There is the ELISA for toxoplasma, serum antibody toxoplasma titer. Serum, that is very important. And that's, if it's a negative, you think about toxoplasma, revise the diagnosis or think of other diagnosis. It's always positive. So aqueous toxoplasmosis in immunocompetent antibody titers do not always correlate with ocular disease. A severe ocular disease doesn't mean high titer. Any antibody toxicity titer initially may be very low. You can need to do an undiluted sample, the toxoplasma titer. We did a study of PCR in toxoplasma. It's not as good as the PCR in other infectious entity like viral retinitis or mycobacterium tuberculosis. Only 33% positive. So if we have that Goldman-Whitmer coefficient, that is the antibody toxoplasma titer in the serum and aqueous, if you do, and that combination is more than 3, and you compare with the along with the PCR results, then the sensitivity is high. And this is an elegant study by my student, Ranju Khorel Sitala from Nepal. He did a vitreous biopsy, and then he did a vitreous biopsy, and the vitreous biopsy, she could demonstrate bradyzoid of toxoplasma was seen in the H&E staining. And this is the tachyzoids also are seen in the H&E staining vitreous specimen. So in case of doubt and the vitreous haze with the retinochoroidal lesions, you can do a vitreous biopsy. And from there, you can see cytologically toxoplasma gondii cyst or bradyzoids or tachyzoids. And this is a very interesting case. This case doesn't belong to me. It's Dr. Narsingh Rao. And this patient was thought to be cytomegalovirus retinitis. He was treated with intravitreal ganciclovir, and the patient was not responding, progressive. And at this stage, they did a retinochoroidal biopsy or chorioretinal biopsy, which is a very dexterous procedure. You need a very dexterous surgeon to put a laser and take a snip of retinochoroidal biopsy. That's what is taken. And I wanted to show you, being a pathologist, I can tell you this is the choroid, and this is the retinal pigment epithelium, and this is a necrotic retina. That whole retinal structures, full thickness retinal necrosis is there, and you can see the toxoplasma gondii cysts are there. And this toxoplasma gondii cyst electron microscopically, you can see the whole family of the toxoplasma gondii is there. So chorioretinal biopsy can be of helpful. Aqueous toxoplasmosis in immunocompromised patient, radiology, serology unreliable due to the depressed antibody response. Nested PCR from aqueous and vitreous fluid is helpful. Combination of the NPCR and Goldman-Whitmer coefficient, as we have told. So if you see immunocompromised, like the patient is HIV positive or on immunosuppression, their ELISA for the toxoplasmosis may be negative. Their PCR plays a very important role. This is one of the important message I want to give you. What is the indication of the treatment? I do treat all patients of toxoplasma, but some people believe that the peripheral toxoplasma can spontaneously resolve. But if you see that within the macular area, there is a decreased vision, peripheral lesion, that need to be treated. But to be frank and honest, I see any toxoplasma lesion, I treat them. And what are the method of treatment? There are the various combination of the treatment is given. I give the treatment with Bactrim DS now. Earlier, I used to give clindamycin, 300 milligram tablet, 1 tablet 4 times daily. And one can give the Pyrimethamine tablet, also it is difficult to achieve it. Pyrimethamine with polinic acid. Brazil people, they give a lot. Sulfarizine can be given. Azithromycin is another drug which can be given in toxoplasmosis. Atovac 1 is another drug which can be used in the toxoplasmosis. So one of the important things which I wanted to mention about you, there's a very good role of intraocular injection of antibiotic. Intravitreal clindamycin for toxoplasmic retinochoroiditis, particularly if it is in the posterior pole. Like this patient, young adult male immunocompetent, has got a lesion bang on the fovea. What we did an intravitreal clindamycin injection once in 3 days, and few such injections you can give once in a week, but once in 3 days is better. Macular lesion, how much you give? 1 milligram in 0.1 ml. And there is a lot of things one of the thing is important thing is that can you give a preventive treatment, prophylactic treatment? Claudia Silveira from Brazil he devised a kind of treatment regimen giving Bactrim DS, trimethoprim with sulfamethoxazole 800 milligram every 3 days, twice a week. Twice a week, giving that one that reduces the rate of recurrence. I do give all patients of congenital toxoplasmosis, children in particular, and the lesions is close to the macula. If there's a new lesion occurs, they will lose the vision. So that to prevent the vision loss, I give that prophylactic treatment, Bactrim DS1 tablet twice a week. Let's shift the gear and show one case. This is an 8-year-old girl present with acute painful red eye, vision with a light perception, inaccurate projection. Ultrasound showed suggestive retinal detachment. Started on topical steroid, AC tab done, was suspected to be toxoplasma. Aqueous aspirate PCR was negative for toxoplasma, but there was a granuloma over there, and this granuloma is very suggestive of toxocara. And fundus evaluation showed vitreous haze, and the patient is under follow-up, but this patient was having toxocara lesion. 2 months back, the granuloma is much more prominent, and it was a toxocara. Toxocara canis, Toxocara cati, two forms. This is the ascarid nematode on the ascarid family. Definitive host is the domestic dog, puppies, and cats. Human is the aberrant host. And as you know, the puppies is the definitive host. I don't want to go to the life cycle, and you can get that stool of the parasite, particularly the children when they're playing in the garden or the playground, they get contaminated soil, pica. If they take the pica, the contaminated mud, they get the toxocara lesion. And this is a lesion. If you see a peripheral granuloma like this, your first differential diagnosis will be toxocara. And it can have posterior pole lesion as is seen in this patient. And this is a patient photograph I have taken long time back, about 30 years back. It is a beautiful peripheral granuloma with the traction, juicy tractions attaching to the optic disc. This is a peripheral granuloma. So what are the differential diagnosis? When there is a posterior pole granuloma, it can mimic retinoblastoma. It can mimic infective endogenous endophthalmitis, Coats disease, familial exudative vitreoretinopathy, persistent fetal vasculature, toxoplasmosis, DUSN, undifferentiated uveitis, retinopathy of prematurity, combined hematoma. Investigations, complete blood count, eosinophil you should look for, IgE evaluation, serology antibody to the Toxocara canis is very difficult to get it. Nowadays is that commercially is getting available, and aqueous and vitreous sampling for eosinophils, antibody detection and PCR method is there. We have detected PCR by Toxocara, ultrasonography and CT scan is helpful. Treatment is very limited. Antihelminthic treatment is of doubtful role. We can give tablet thybendazole or mebendazole, and their role is doubtful because by the time we see the parasite is dead. Steroids is local and systemic corticosteroids is the mainstay of inflammation treatment to reduce the inflammation and minimize the structural complications. Vitrectomy is very helpful for sight-threatening complications, remove all the bands and vitreous haze, and prevention good hygiene practice and deworming of the pets. This is a study we did it and it was published in Ocular Immunology of Inflammation, Ocular Toxocara, valid presentation, serum ELISA for Toxocara canis aids in the diagnosis. The difference in the visual outcome of the clinical and treatment group was insignificant. Ocular toxoplasmosis resulted, it's not a good disease, poor visual outcome. Most of the patients had poor visual outcome. In contrast to the toxoplasma. Toxoplasma is a very good disease. Toxocara is not a good disease. I don't keep dogs in the house. One of the reasons is I don't want my child to have developed toxocara. I might sound a little eccentric, but I'm really afraid of toxocara. What is this? Can anybody tell that one who are in the audience? These two, any of you?
That looks like cystic space, like in the anterior chamber, probably a hydatid cyst-like appearance it has.
It's a cystic sarcus. We saw this case with Padma Malini from Bangalore. She was not sure. She sent it to me. I found that there is an evaluation occurring through the light, examining light. And it was a cystic sarcus. We published it with Padma, fibrinous anterior uveitis due to the cystic sarcus cellulosis. Cystic sarcus is the most common ocular platyhelminth infestation in humans caused by the larva of the tapeworm Tinea solium, and Tinea sagittaria is cystic sarcus bovis. Tinea solium is producing cystic sarcus cellulosis. Definitive host is human. Intermediate host is pigs. And you get the pigs, uncooked pig one, and this can produce the cystic sarcus lesion. And one of the tennis player, Leonard Pace, had cystic sarcus in the brain, neurocystic sarcus. Ocular manifestation can be devastating as the cystic sarcus increases in size, leading to the blindness in 3 to 5 years. It's not a good disease. It can lead to blindness. Death of the parasite cause marked release of toxic products, leading to the profound inflammatory reaction and destruction of the eye. I had a cystic sarcus slide where the cystic sarcus is producing so intense PMN reaction, polymorphonuclear leukocyte reaction. I don't have the slides. During the transfer of my lab, I lost the slide. That would have been a very good example of this. Most common involvement is the vitreous and subretinal space. It can be subconjunctival space, anterior segment, and can be in the orbit. Bilateral cystic sarcus optic nerve defected man who presented with the features suggestive of optic neuritis. This is a publication, we are proud of it, and this is the publication in Ophthalmology Journal. Intraocular cystic sarcus is very well quoted by Dr. Tarun Sharma, and we found that this is a blinding disease, ambulatory vision in 67% cases only. So even if you do the treatment, and this is an elegant histopathology of removed cystic sarcus, and you can see the scolex over here, and this is a scolex, and this is surrounded by the cell wall of the cystic sarcus. And this is a neurocystic sarcus associated with the seizures and hydrocephalus, may cause bilateral disc edema with macular serous fluid, observation of cystic sarcus organism within the eye, ELISA for antibody for the tinea may be helpful. And then what is the treatment? Praziquantel is one of the treatment for the cystic sarcus, neurocystic sarcus. Treatment, albendazole, 50 milligram, praziquantel, as I told you, 50 milligram per kilogram per day during 15 days. And laser photocoagulation you can do. Early surgical intervention, removal of the cystic sarcus is the best thing to do. I published a subretinal cystic sarcus in a patient with AIDS. That is a coincidental, and which was treated with a general photocoagulation, which I showed you in the first picture of that one. Beautiful cysticercus. And what I want to tell you, if you see an endogenous endophthalmitis, don't forget that it could be cysticercus. This is one of the patients who had endogenous endophthalmitis, has got something monster-like things inside the eye. And then what I did ultrasound, and ultrasound picked up the cysticercus scolex, high reflectivity. And then histopathology showed that the hooklet of the cysticercus. This is a very elegant case, was published in Ocular Immunogen Inflammation. There can be mild cysticercus. You can see one of the muscle get involved with the cysticercus. Ultrasound will be showing the very characteristic cysticercus cyst to the scolex. And this is a small video will be showing you this given by Pramod Vinde. And you can see that how a cysticercus is there in the cyst and how it is removed. And this is a difficult thing to do. You can chew it up, but nowadays somebody does the chew up also. But you can make a small opening on the adjacent to the cysticercus cyst. That's what they did it. And you can see that it's an enjoyable video. How we are trying to catch the cysticercus. You can see that this is undulating. Make an opening over there and then went to the forceps, catch hold of him, and then that parasite is bulged out and is removed total. And it will be a pathologist pleasure to look into that cysticercus. I did a video of that parasite moving around that one with the cysticercus scolex, which I published, presented in the Argo. And you did the photocoagulation and that opening which you have made. And then some of the cases of endogenous endophthalmitis, you should do a ultrasound and look carefully the cysticercus scolex. And it's very elegant. Once you see it, you can make a diagnosis easily. So in endemic country like India, intraocular cysticercus will be kept in mind in the differential diagnosis of any patient with uveitis having cystic lesion. Many topical and systemic steroid to control the inflammation, because when the cyst bursts, it produces intense inflammation. And surgical removal of the cysticercus cyst in toto can cure the uveitis.
No.
Filaria. Filaria is that the Onchocerca volvularis, Ucheria bancrofti, Loa, Deccanquez, and the most common is the Dirofilaria. It is a zoonosis caused by the Dirofilaria species. It causes pulmonary, cardiovascular, and subcutaneous infection. Ocular involvement is, however, rare. So they can involve the eyelid and orbit is the common, and subconjunctival 26%, intraocular can also occur. This is one of the case, intraocular Dirofilaria, which you have described. You can see the Dirofilaria worm over here, and they produce multiple chorioretinal atrophic patches. So when you see multiple chorioretinal atrophic patches, think of Dirofilaria in our country. And this is one of the video of a Dirofilaria dancing. Very fast. There is surgical removal is a challenge. Antechamber parasitis and local anesthesia. Diethyl carbamazine given in 2 divided doses in 3 weeks. And it was found to be 27 millimeter long and 0.5 millimeter wide. Both the ends were tapered. And this is a Dirofilaria of the subconjunctiva. Redness and pain for 2 years. This is more common in the Kerala. Diagnosis of chronic episcleritis. On examination, they found in the worm sitting over there, coiled worm. And you see that this is not long worm, This is long one. We should see that how subconjunctival diaphragm. Just make a nick in the conjunctival space and then it's removed. You see the long worm. Mosquito is the host for this. Mosquito bite, you get that one. It's very common in the Kerala. It's still coming. It's difficult to measure in the microscope also. Okay, this is a parasite. And you suture it, and you go. And this is we published in Ophthalmic Infection and Inflammation. Not only we did that video we showed, we are under cover slip, we described the tapered end of the parasite. This is the head end, and this is the head end of the parasite, and this is the caudal end of the parasite. And this is the scanning electron microscopy. We have done that one. This is the head of the worm. This is the head of the worm. And this is the parasite with the body wall of the parasite. Okay. And this is the tail of the worm. You can see the striations. This is a case, 20-year-old male, hypopia and uveitis, reflected the topical and systemic steroid. I didn't know what to do about this case. I was not sure what was the diagnosis. Adult male, hypopia not responding. I asked Dr. Badrinath. He said, go ahead and do a tap. I did a tap. I sent to the pathology laboratory. Laboratory technician called me, sir, please come. And I saw that one. I was surprised. There was a microfilaria in the anterior chamber. Night blood showed microfilaria. I waited till 9 o'clock and took the night blood, and the video of the night blood I taken. So microfilaria, I have not seen second case after this. Microfilaria causing hypopia and uveitis. Like Brugia malloy in the anterior chamber, a case report from India we have published. And this is a Brugia malloy, and you can see the parasite in the eye. And polymerase chain reaction, we have done a recent study, direct ocular diaphragm with the parasitology department of the veterinary college. We could find out the species of the diaphragm. It was diaphragm repens, which is the most common. And then I'll show you one case. This is a very interesting case. This is a 39-year-old female, wife of a priest. Associated redness, pain, and headache. No similar episode in the past. No past history of tuberculosis, atrophy. No history of trauma. No complaint of joint pain, oral ulceration, urinary tract infection. No complaint of pruritus. Vegetarian. And this patient had BCVA 624 and all. And he had flare and cells, fibrin and iris holes with streak of blood clots. When he looked into fundus, we thought that is a central retinal vein occlusion. And this was the, what is your suspicion? And this patient, eosinophilia, no, they are not there. Yes, are normal. CT brain normal. We are at a loss. What to do? And then oral and topical steroid patient came on follow-up. On the next day, worm was found in the AC. But we took the patient to the photography department. By the time we went to the photography department, the parasite disappeared. There was no parasite in the anterior chamber. Everything was clear. Photographer was telling, what are you talking? Then we did UVM. We found that the bug is sitting there behind the iris root. And this we published in the American Journal of Ophthalmology. And then 2 weeks after, we got the parasite over the eye. And this time we didn't take chance. Immediately we took to the theater and we removed the parasite. How we removed, how challenging is removal of the worm. This is the parasite. You try to suck with the forceps, And also Sankara, we wanted to do it. It didn't come. We put an air bubble and try to take it over there one. We just see, be patient. We were patient to remove the parasite. It was very difficult to remove the parasite, moving parasite from the eye. Then we went there, we made a nick over there and we cut the iris. We pulled the iris. We tried to pull the parasite, but couldn't get that one. We took, the parasite did not come, iris came. And this is the iris tissue. We tried to cajole the parasite and take it out. Took a half an hour time to get rid of that parasite. But best thing is to remove it. So then we just scissor, we cut the iris. Now we put the forceps, try to take it out, couldn't do it. Then we just enough is enough. We catch hold of the parasite by forceps and brought it out. And this is a parasite. Nathralaya spinism, head end, cephalic end, and it was described by Richard Owen, and there's several species. I don't go into details of it. What is very characteristic in the hole in the iris, they produce hole in the iris. They can go from anterior chamber to the vitreous cavity to the anterior chamber. They migrate. And we'll show you one of the migrating parasite. Dancing parasite. What they do is that they produce iris holes in the eye. These are the iris holes. They produce membrane in the vitreous, inflammatory membrane. And these are parasites, bowing. This parasite is removed total. And this is the underneath the cover slip mount. You can see the Nathralaya spinism. This is a scanning electron microscope picture of that parasite. This video won that award in the AIOC. This is a parasite, another parasite. This is a parasite under the microscope. These are the track they prepare, they produce on the migrate to the front and back. Multiple iris holes they can prepare, they can produce. Larva can migrate from the anterior to the posterior chamber. So ultrasound biomicroscopy, we did that one parasite. And this is a scanning electron microscopic photograph of the parasite which I've shown you. Let's see a case. This is a case of a bot fly producing the inflammations. And we could identify the bot fly and this producing a OCT picture. First time OCT picture of the bot fly was done. This is another parasite, Linguetta serrata, and it's not been described in the literature. And you can see that the monster is moving. This has got a spine, a very peculiar picture. Moving inside the anterior chamber. Okay. And diffuse unilateral subacute neuroretinitis, we have got a patient. This is a DUSN and is a biphasic condition. Fundus early stage shows multiple post-equatorial evanescent crop whitish dots. And you would be seeing this kind of a whitish dots in the eye. And really small retinal granuloma. And treatment is laser photocoagulation can prevent disease progression. And this is a case with a live intraocular worm present as a DUSN. We could do an OCT. We published in a photo essay in Indian Journal of Ophthalmology. And this is a parasite we picked up in the very tiny parasite. Could find out by OCTA. And last is the hydatid cyst. Hydatid cyst is echinococcus and most commonly seen in the liver and lungs. I just don't want to go into details of the one. There's an intermediate host is there, is joining the dog or sheep. Ocular involvement, most common is the lateral and superomedial angle of the orbit. Orbit is the most common site. I didn't deliberately discuss the orbital parasite that much. Intraocular parasite I have discussed. And one of the important ultrasound finding is the it's called double wall sign. Two walls can be seen because it's a trilaminated wall. I did a lectin study of the wall of the hydatid cyst. And these are the two cases of hydatid cyst rolled up ultrasound and CT scan I described. And in the literature orbit journal. So disease is abscess, orbital hematoma, lymphangioma, lacrimal cyst, dermal cyst. Treatment is albendazole with steroids. Last is the ocular malaria. I had a patient who came from Gujarat. He went to Kodaikanal for that one and then bitten by the mosquitoes, Plasmodium falciparum, developed cerebral malaria, died. And the eyeball was completely full of retinal hemorrhages. I did a microscopic study and within the quartal blood vessels, after a few days of search, you can see that malaria parasite over there. And there's a rouleau formation of RBC. This is a platelet. RBCs are rouleau formations and they get adhered to the cell wall. So clinical pathological study of the parasitic eye and orbit we have done. Most of the thing is in the lid and orbit. Cystosarcus intraocular is less common. And tenon cyst is also seen over there. And this is a dirophilaria. You can see that parasite, if you don't remove it, it produces such an intense reaction in the eye that it produces inflammation and structural damage to the eye. And this is another parasite of diarrhea. You can see there's so much of inflammatory reactions it produces. I can go on talking on parasite. This is close to my heart. I end it here. Parasitic infections are exotic in nature, with exception of ocular toxoplasmosis, which is one of the common cause of posterior uveitis. It is essential to maintain a clinical suspicion in our country. Parasitic infection in addition with atypical ocular inflammation like syphilis. We should think of parasite inside the eye, particularly endogenous endophthalmitis. Targeted organism-specific medication therapy is essential, but most important, if we can see it, remove it. Thank you very much for the kind opportunity.
Thank you so much, sir. That was really a very interesting class, a wholesome class, in fact, with pictures, videos, which we very rarely get to see. Actually, you have a great collection of all this. We are really honored to learn from your experience, sir.
Thank you very much.
Just a couple of questions before
Sure.
we end, sir. So, in what cases of these parasitic infections should we do an AC tap?
So actually, if you see in fact, the ACTAP is not really required. And parasitic infestation, if you see that parasite, you should remove it. I have done the ACTAP for parasitic infestation suspicion in one case only. So ACTAP is not the diagnostic test for one. Careful examination, ultrasound, UBM, and nowadays OCT and DUSN is that can help in the diagnosis imaging technique. You don't need to do a CTAP.
Okay. You had actually mentioned about epidemic outbreak in the city of Coimbatore. So
Yeah.
when such a public health concern comes, how do we tackle it from the...
You must bring to the notice of the municipality commissioner that this is the mode of transmission, and cats should be really should not get in touch with the common water tank or sewer this place. It's very important. They did that work. They brought to the notice of the municipal. There are only one or two incidents of this kind of community outbreak of toxoplasma.
Okay. What in ocular cysticercosis, you gave the whole protocol of management. What is the role of steroids, sir, in it? Do we prescribe it?
So once you see it, you give oral. Once you see it, you remove it. And if it's degenerated and it produces already damage or produce toxic infection already, the cyst is ruptured, then you give oral steroid, 1 milligram per kilogram of the body weight. But if you can intact parasite without any inflammation, you don't need to give oral steroid.
Okay, sir. This is a very commonly asked questions to the postgraduates. How do you differentiate a dead cyst and a live cyst, sir? Is there a technique to it?
I do it under the microscope. Dead cyst will not move. Live cyst will be moving in that one. Indolation will falling of the light. Will be seeing on that one. Sometimes we thought that is a dead, and when we remove the parasite and see, particularly nephostoma, we think that under the microscope it's slowly wriggling. So it's very difficult to make out whether it's dead or.
Okay. In ocular cysticercosis, if there is a live cyst, do we directly go on to doing the surgery, or we give a protocol of medical
No
management?
medical treatment. Best thing is to remove it.
Okay. Okay.
If the parasite dies inside the eye, it produces intense reaction.
Okay.
Except orbital cysticercosis, which is difficult to find out, then you can give a treatment for cysticercosis along with steroid. Orbital cysticercosis. Intraocular, no. The big no. Because it produces toxins are so high, it produces so much damage. I had I'm really very sorry that I couldn't show that parasite. Head of the parasite is infiltrated by intense polymer morphonuclear reaction. Such a toxic reaction it produces.
Okay, sir. And the last question, sir, in toxoplasma chorioretinitis, is there any particular change we see on the OCT?
Oh, that is the big subject. I'm working on it. You know
Okay.
that it's a retinitis, and it produces a small amount of choroidal involvement. Initial stage, it will start with retinitis, but later on, if you follow up the cases, retinochoroiditis. In fact, I've done about 50 cases, and the paper is in process. And is a full thickness retinal necrosis. OCT is very characteristic. It can differentiate from tubercular chorioretinitis, while choroid is the main site of involvement, and toxoplasma will be the retina, will be the main site of involvement.
Okay.
And always see the vitreous cells in the toxoplasma. A good OCT you will be able to pick up.
Okay, sir. I think one of our panelists, Dr. Farnaz, also had a doubt. So,
Please.
Yeah, so I have one doubt, sir, regarding B-scan, its usage in cysticercosis, especially when it is actually in the extraocular muscle thickness. We actually go ahead with MRI these days, but in case if we have only B-scan, how does it help in
Scolex. Scolex you will be able to see. That spot, bright spot in the outer sound, hyperreflective spot. In the cystic space, one bright reflective spot seen is cysticercus, unless proven otherwise. It's so classic.
Okay, even in the extraocular muscle, when we use a scan probe, we can actually identify it.
Yeah, you can definitely identify. You can start treating it also. It's so diagnostic.
Okay. Thank you, sir.
Thank you. I'm still learning parasites in the eye, and it's really an exotic thing. And every day parasite comes, my technician tells that, sir, another parasite has come. I try to diagnose it and trying to correlate. Some of the parasites I have published it, but I have got a number of parasites which I have not published.
thank you so much, sir. We hope to read your publications that are hopefully coming up soon, because there's so much to learn from you. A man who's been practicing for so many years in both retina and uvea would have so much to offer for all our youngsters. So thank you so much for
Thank you very much for
having
listening.
you here on our iFocus platform, sir.
Thank you.
Before we end this session, I take this opportunity to again remind you all about the iFocus 2025 offline session, the National Postgraduate Education Program in Ophthalmology. This time would be held at New Delhi. It's commencing on the August 10th until the 17th. It's a whole amalgamation of practical aspects as well as theoretical aspects, like a nutshell for your postgraduate education. We're hoping to see you soon over there. Do enroll yourself soon. The seats were limited to 300, and I think there are very few countable numbers of them left.
Okay.
Biswas sir would also be joining us for the offline session, sir, this year.
Okay.